Good morning, good morning, good morning, and Happy New Year. And not only is it a great new year we've now entered, it's also a new day. So I'm going to say Happy New Day because I know we cannot take each day for granted. So I'm just happy to be here today. So Happy New Day and welcome to the Great Lakes Health Radio program on Power 96.5. WUFO 1080 AM. I am your host, Francesca B. Messiah from Kaleida Health with a new title. I'm the manager of community health engagement. And my responsibilities have slightly changed. However, I do have a new title, the manager of community health engagement here at Kaleida Health. Kaleida Health is Western New York's premier and largest healthcare system in the area in Western New York and parts of Pennsylvania, employing over 11,000 employees. Kaleida Health does not discriminate, exclude, or treat people differently because of race, color, religion, sex, national origin, disability, sexual orientation, gender identity or expression, physical appearance, or source of payment or age. Well, Kaleida Health, please, we look forward to taking care of your loved one, taking care of you. And we also welcome you to, if you need a physician or you're looking for different health services, to please become part of the Kaleida family. Well, our guest for today, this year, as every year, I'm always trying to focus on topics that are in the news and just topics that might interest you. So again, I've been saying this for years. When I see you in the community, please let me know what topic you would like to hear, because this program is for you, our community. First I'll say our guest. Our guest for today is Rianne Neham. Is that how you pronounce your last name, Rahan? Or Rianne?
Rhiannon Needham, just Needham.
Rianne
Yeah,
Needham.
the confusing.
Okay. Rianne Needham. I was way off. I apologize.
That's okay.
And Rianne is the birth equity coordinator, and she's a doula. And we're going to be talking today about her role as a birth equity coordinator here at Kaleida Health and a doula in the hospital environment. Doula is one of those terms you hear about more and more and more on the news. And a doula is talking about women delivering children, delivering babies, and a coach, like having a coach. But I'll let Rianne tell us more about that. As we were just talking about, what was it before we started the show? We were talking about someone who had five babies. What was that? Was it What's the medical term?
Yes, quintuplets. Yep.
Quintuplets. And I know she can even help women who are delivering quintuplets. But anyway, on with our show. Our first question. Please explain what birth equity is and how long has a department within Kaleida Health of birth equity been in existence?
Sure. So birth equity pretty much means that we're making sure as a system that everybody has the opportunity to experience a healthy pregnancy, healthy birthing experience, healthy postpartum experience. So just ensuring that regardless of some of those diversity identifiers that you mentioned in the beginning, race, ethnicity specifically, because there are some specific groups that are marginalized. It really recognizes that the difference in birth outcomes are not due to individual choices, but really due to those systemic factors, structural racism, bias, and some social conditioning. So, really just focusing on removing those barriers and making sure that our care coordination, our design, our policies, and any support procedures that we have in place within the system are structured intentionally. And that's sort of meant to be using community resources, using support individuals like doulas, and making sure that families are treated with that dignity, that respect, culturally specific and responsive care, and make sure that they have the support that they need. I would say just with how long the department's been in existence, uh, we're not really a specific department. I'm the only birth equity coordinator here. We're under the Department of Diversity, Equity, and Inclusion, but I would say that there have been individuals working on birth equity efforts within maternity departments and things like that for many years.
And I know you're currently under diversity, equity, inclusion, but um, by the time the show is aired, you'll probably be part of the Department of Human Resources.
Yes, yep,
Yeah,
under the community health improvement team. Yes.
right. Yeah. Yes, because yeah, we'll be serving on the same team. One of the most important things that I caught in what you said, and I don't want it to get lost, was in the very beginning. I guess almost call it the blame game. And what you said, it was, I would say it's demystifying the blame game because you said that many birth what outcomes are not due to the individual. So
Right.
you're saying there are things, and it's been documented that and I'm assuming it's been documented that what you're saying, there are things in the system for for different populations who have not had good results with childbirth. It's not their fault. Is that what you're saying?
Exactly. Yeah. So, historically speaking, especially in the United States, Black and Brown women, Black and Brown birthing individuals, and family members specifically have had worse outcomes, especially related to birth. The maternal mortality rate, which is relating to individuals who die during childbirth, um, is higher amongst Black and Brown populations than their white counterparts. And that's just one example. There are so many different, we could spend 2 hours talking about just the statistics around specific communities, but making sure that we are identifying the why behind those numbers, and is it related to individual bias? Is it related to systemic racism? Some of it's related to the way specific medical procedures or studies were conducted when they were first sort of created or thought about. And now we've been practicing in that same way for a long time. So just keeping up on modern evidence-based practices and ensuring that we're creating the proper interventions or looking out for some of those things that impact specific populations more than others.
What piqued your, and this wasn't one of our questions, but I know you can answer it. What piqued
Yeah.
your interest? So what piqued your interest in working in the area of disparities of women and babies during birth? Like what has because it's been going on since slavery. I mean, it's
Hmm.
I'm glad that it's now being documented. I'm glad and equally ecstatic and thrilled that the Kaleida Health is now part of looking at the numbers of, why this is happening. But what piqued your interest in doing this kind of work?
Yeah, so well, I would say a little bit of it was accidental. It's not, I was never, when I was younger, saying that this was anything that I was going to do. I actually wanted to be a veterinarian, so totally different. But
No, no, still
I
working with, yeah, living people, right?
working with living, yep, living animals. But
Living animals, right?
um, so I think really I about 10 years ago started my journey into psychology. And when I was learning about some of the things related to psychology, I was really interested specifically in reproductive health and reproductive psychology. So there's not really in many programs, specific courses or extra education that you can do for reproductive psychology specifically. So I kind of sought that out on my own and then eventually worked myself into some doula trainings and things purely educationally. Never really had any intention of doing this work. And then just learning more about it and seeing some of it firsthand, it just really felt like something that I couldn't not do. It was something that I said, I want to be on this side of advocacy, and I know people who have gone through this, and I've never really known the ins and outs of it. I've just sort of heard about it. And I want to be somebody who's directly involved with the change
And
as far
part of it, it
as.
sounds like it's a passion,
Yeah.
and that's great. I just wanted the listeners to hear about your passion, which has led to a career.
Mhm.
So what departments does Birth Equity collaborate with within Calida or even within the county, within Erie County?
Right, quite a few. So within Kaleida, really any of the maternity-based departments. So we have labor and delivery, mother baby for after birth. There's also our NICU and maternal fetal medicine departments. Those are all inpatient. Maternal fetal medicine also, they have outpatient components as well. And then there are all of our outpatient OBGYN clinics that we work with too.
Okay, thank you. And in the past, was Birth Equity known by another name? And I think of the word social determinants of health. There were many names which kind of rolled
Hmm.
up into what is now social determinants of health. However, in the past, is there another name that birth equity may have been referred as?
Probably, probably not explicitly. I think it more so some of the work fell under the umbrella of other things. So I think that people were doing the work without a name is more so what it was.
Okay, all right, and that's fair. That's possible. And talking about social determinants of health, is birth equity a part of it?
Definitely. Yeah, it's very connected. There are a lot of social determinant of health factors that go into it, like access to prenatal care or transportation to prenatal care. Transportation is a big one, or childcare for other children, not being able to go to a prenatal appointment or receive any of that care during pregnancy because of those things. Safe housing, nutrition, insurance, all of those are very aligned and very related and definitely influence an individual's pregnancy, their birth outcomes, and their postpartum experience.
Oh my
So it
goodness.
really, yeah,
Yeah.
it focuses on, um, in birth equity, we focus on that everyone that is of reproductive age, I'd say. You don't even have to be pregnant at this current moment, but anyone who's of reproductive age has that support, respect, and those resources that they need for a healthy pregnancy, a healthy birth experience, all of that, regardless of their race, income, zip code, uh, anything, and that we can try to get them or fill those gaps for the resources that they're not able to have.
So really going back to what you originally the first question talking about birth equity, you're saying that having lack of transportation to your appointment, access to get to there, your health insurance question, which is huge right now,
Hmm.
safe housing, nutrition, race, and zip code, all of these things can make a difference in bringing that adorable little person into the world.
Absolutely. And so there are different models, of course, that historically speaking, people may not have had as many prenatal appointments, things of that nature. But when we're looking at some of these outcomes, especially for certain populations, the benefit to prenatal care is really ensuring one that everything is going in the right direction for you and your baby, as far as like growth and things of that nature, but also making sure that things that need intervening are caught early, like high blood pressure or gestational diabetes or those types of things. So if you think of the things that somebody might experience during pregnancy, catching those early rather than when somebody goes into labor sometimes early. So for example, if I'm just speaking in broad terms, access to prenatal care and catching things early can reduce somebody's risk of preterm labor. So reduce somebody's risk of having their baby early, which could potentially lead to a NICU stay, which is very costly and can sometimes be really overwhelming on a family who the birthing parent might have been discharged, but now their baby is still in the NICU and now they need to come back and forth to the hospital because they're not admitted to the hospital anymore. So it's just sort of this cascade of things that can happen without access to one thing. So making sure that everybody has that opportunity that so many of us take for granted of just being able to go to your doctor's appointment.
Yeah, no, that is huge. If someone is interested in having you speak to their group um, about this topic,
Mhm.
how would they contact you?
Sure. Yeah, I have a phone number here. It's 716-859-4657. Um, or, even if you go to the Kaleida Maternity website, there are ways to kind of get in touch as well. But phone number is easiest. Just leave me a message if I'm not in the office.
Thank you. And if you could give that one more time, please, one more time.
Sure, sure. 716-859-4657.
Thank you, because it's such an important topic. Um, and we may have to do another show on doula, but we're going to start right now. We hear about doulas all the time on TV. Um, we've had many conversations on doulas, but for those who don't really know what it is, and maybe it's their first time hearing the word, what is a doula, and how long has a doula been practicing? I'm going to say in the U.S. How long has this practice been in the U.S.?
Sure. So, the word doula itself is in some circles controversial. It really depends on who the individual is because it's actually a very, very old word, coming from ancient Greece, and it means a woman who serves. So people don't really like the servant connotation around it. It really depends. A lot of us actually just refer to ourselves as birth workers, but doula is the most recognized term. So it really just depends on where you are. But the modern term was, I think, I don't have all of the statistics in front of me, but I think closer to like the 1960s, um, when they really assigned that sort of to childbirth specifically, because it was definitely broader when it was originated. But a doula in general is a trained professional who is really non-clinical, so we're not doing medical procedures, not even really like blood pressure checks or things like that. We're working alongside of the medical care team. That could be a midwife, an OBGYN, nurse practitioners. Um, and doulas are providing emotional, physical, and informational support. So, really through education to individuals and their families. And the family aspect of that is really important because doulas are not just for the person who's giving birth. We're there to support the entire family. I do a lot of partner support, um, and that's before, during, and after childbirth. So it really just depends. There are birth doulas, there are postpartum doulas, there are full spectrum, even fertility doulas. And then there are death doulas who really help transition in the opposite way, transition somebody out of the world. So, uh, again, doulas aren't replacing medical providers. They're working alongside, complementing that clinical care and offering continuous support to help families, making sure that they understand their options, making sure they feel heard and respected, and really empowered. I think empowered is the biggest word. They want to be able to make those choices on their own. So doulas are empowering them with the knowledge and with the research to be able to say, yeah, I definitely want to go this route, or no, respectfully, I'd like to decline that.
And again, and what's really important, another word I pulled out of what you said was the word family. They educate and they work with the family because bringing a
Yes.
new person into the world definitely takes a family. I have
Mhm.
little cousins, and I'm beginning to understand.
Yes.
It takes
Full circle.
a true village.
It takes a
Yeah.
village. Yep.
hmm Um, so and a doula, so for I'm just gonna say it's a birth worker, or in the Bible, it's a woman who serves. So I just want to make sure that take away from our listeners that they understand that. Now, doulas are non-clinical. So then, what then makes a doula that person who works alongside the medical team during childbirth? What type of training does a doula receive for this important work?
Yeah, so all throughout the US actually, and in specific states, doulas are considered non-regulated, which means there's not, as you would think about a nurse, how they have specific exams and licensure requirements. There are really just minimum either training or experience hours that need to be met, to be considered a doula. So everybody trains a little bit differently. Some doulas are trained in what could be considered a traditional sense, where it's knowledge passed down from ancestors who have done this work, or community members who have done this work, and then sometimes it's going and sitting in a classroom and receiving some formal training. But then there's also an additional experience piece to that before you can be considered certified. Uh, doulas don't necessarily have to have a certification, they just need to meet those educational and experience requirements. Um, and there are so many different trainings throughout the US and throughout New York State, and even locally in our area, where doulas can receive that formal education and sort of shadow or go along with somebody else on that experience.
Okay, before we get to our last question, if somebody is interested in becoming a doula, how would they contact you?
Yeah, so actually one of the easiest ways is, on the Kaleida Health website, there's a well, first you can always use my phone number, like I mentioned, but there's also a doula page under the maternity page, and it has information about practicing doulas in the area. My information's on there as well.
If someone's like me and they're a horrible speller, how do you spell doula?
Oh, sure, sure. It's Doula.
Thank you. Yeah, because I know I was trying to look it up, and spelling was never my strength in school. And I finally found it. So just in case there are some listeners who are like myself. Well, you know
Mhm.
what? I have to cut out a couple of questions, but I'm just going to say, what are some closing remarks that you would like to say about either doula or birth equity? You have the last 2 minutes.
Okay, sure. Yeah, I mean, really, just in general, I think that one thing we didn't touch upon that could be really important, talking about the birth equity and the access piece, is that in New York State, and there are plenty of opportunities for this in Erie County specifically, or Niagara County, um, doulas are can be approved Medicaid providers. So if individuals are eligible for Medicaid or Medicaid plans, even if they're through something like Blue Cross Blue Shield or Fidelis or something of that nature, you could, if it's something that you think you might not be able to afford out of pocket, you could potentially be eligible for your insurance to pay for it if you have Medicaid health insurance or a Medicaid plan. And really, what that looks like is on the New York State Department of Health website, they have a list of New York State doulas who are aligned with Medicaid programs who can accept your insurance so that you have no cost out of pocket. They cover prenatal visits, the actual birth, and postpartum visits. So there's opportunity for more doulas in the area to contract with Medicaid plans to continue to align with that work because it's really important to improving access. And hopefully, I think there are a lot of us in New York State working toward getting other insurances to cover doulas as well so that anybody and everybody can have access regardless of eligibility.
Well, thank you, Rihanna. And we are out of time. And I want to thank you so much. We will be replaying, we will be airing this program more than once throughout the year. I will be birth equity coordinator at Kaleida Health and talking about doulas in a hospital environment. Listeners, thank you for listening. Rihanna, thank you for being our guest. Stay tuned. Within 30 seconds, we'll have the second part of our program. Thank you for listening to the Great Lakes Health Radio program on Power 96.5 WUFO AM. And now on to part two. And welcome back to the Great Lakes Health Radio program. And this is our first program, well, technically our second program, because our first one was at 7 a.m. So this is our second program at 7:30 a.m. And our topic for today, and I have to say, not just for today, at the beginning of every year, I always like to have a topic that I know is on many of our listeners' minds, and because you always see it on TV. What is that? Obesity? Yes, we know about obesity, but what about obesity, weight loss medication, and existing treatments? And I just want to let you know, listeners know, that more than likely this is going to be a two-part show. So we will have a second part within the next 2 to 3 programs. And you know what? I didn't introduce myself. Francesca Messiah, Kaleida Health. I do have a new title now at Kaleida Health. I was manager workforce development, and my new title at Kaleida is manager of community health improvement. So it does not affect the radio program at all. I'm just making you aware of the new title. And our guest for today, not a stranger to the Great Lakes Health Radio program, and her name is Dr. Ashley Bernotis. And Dr. Bernotis, good morning. How are you?
Good morning. I'm great. Thank you for having me.
Oh, you're welcome. Dr. Bernotis is a director of obesity medicine, Kaleida Health, and Weight Management Center. She wears a lot of hats, does a lot of things in the area of weight loss and obesity, and helping our community to maintain healthy weights and have conversations about what is a healthy weight. And that's why we probably will need more than one session. So again, the title of today's program, Obesity, Weight Loss Medication, and Existing Treatments. So Dr. Bernotes, if you could just start off with, describe what is obesity, and most importantly, what diseases are associated with obesity?
Yeah, so that's a great question, and I think that the answer will differ by who you speak with. So, but in general, obesity is an excess amount of fat, the fat that is extra to the fat that you actually need on your body. So we all need a certain level of fat. It protects our bones. It helps manage and regulate our hormones. But there's a certain point when too much fat can cause some problems. And those problems, most are very common problems that are associated with excess fat are type 2 diabetes, high blood pressure and heart disease, stroke, fatty liver disease, which we're seeing a lot more of nowadays because of weight and not necessarily alcohol use, which was a big issue causing it in the past. Sleep apnea, that's a very big one that's correlated with excess weight. And then some arthritis on your joints and certain cancers. So there are quite a few, problems that could be improved upon or possibly prevented with weight management.
Hmm. Thank you. You know what? If we've always had obesity, in our country or in the world, but if I'm talking about the country, if we've always had obesity, please discuss what is the concern of one's health, and is obesity genetic? Why it just seems like all of a sudden obesity the past 8 to 10 years has hit central media. So why is it all of a sudden now? And is it genetic? Is it from generation, from families? And yeah.
I think that's a great question because if you look back, generations ago, they didn't struggle as much with their weight. It is definitely on the rise. It is going to, unfortunately, continue to rise before we can actually try to mitigate it or improve it. But now we have some resources to help. So I think it's more talked about now because we actually have resources to help. And for the longest time, doctors didn't know what to recommend: diet and exercise, and that's all we had in our toolbox. And now we have medications and we have reasons and we have genetics that trace back to it. So to your point, yes, it is genetic. There's a genetic component. About 40 to 70% of the reason you're struggling with weight is due to your genetics. And then the rest is your environment. And so the ultra processed foods that we eat in the United States, especially, and developed nations are contributing to that. Preservatives, also our ways of life. So we're more sedentary. We're sitting down more. We are driving everywhere, right? Back when cars were first invented, not everyone had one, and they had to walk places or use public transit. And now we have the luxury of having a vehicle at our disposal. We have, groceries that get delivered to our home. We have food services that get delivered to our home. We have ways to make us less active. And so, it's a culmination of things. It's a combination of things, actually. It is the fact that we are becoming more sedentary, not moving as much. We are eating food that is not as healthy for us, and our genetics are playing a role. And, as we evolve as a society, those genes are mixing, and genetics related to weight are mixing with other genetics related to weight and causing more problems.
Oh no, that sounds awful. Um, but also we have to also add, we now have electric bikes, so
That's right.
you have to pedal as hard, and then you have scooters, the scooters that you see people riding in the street. So
Yeah.
I'm waiting for the electric skateboard next.
Which are, and to, I prefer an electric bike over some other, forms of
Totally.
transportation, because at least you have the option of also using the pedal, not
Oh,
pedal assist part. But I would say that, yes, and for certain conditions, of course, people need those scooters, and they
yes.
need that. And I understand. But some of those conditions are actually, in fact, caused by weight. And can we fix and improve the weight so that they don't need those and they can move around more easily and feel more inclined to exercise?
Hmm. Um, since our last conversation in 2025, how many weight loss, and I'm just changing the subject a little bit. Since our last conversation in 2025, how many weight loss medications are available? And do you have to be diabetic to start weight loss medication? That's a personal question that one of my friends and she always says you have to be diabetic. And I thought I recently read where one of the medications, instead of being an injection, there's oral medication. So I guess first of all, starting with how many weight loss medications are available, and do you have to be a diabetic? Those are the two major
Mhm.
ones.
Yeah. So number one, no, you don't have to have diabetes in order to qualify for the weight management medications. There are weight management medications for patients with diabetes, but there are also some that are available to patients without diabetes. So you don't have to have diabetes in order to get some help with weight management in the form of medication. And as of our last talk, currently there are 8 FDA approved anti-obesity medications. Okay, and There's only been one new one that came out literally this week. It's coming out. It was approved by the FDA the week before the holidays, and that since our last talk, there's only been one new one, and it is the pill version of Wegovy. So Wegovy was only an injection form. You could only get it as an injection, quite expensive, and that really caused a lot of people to not have access to it because of the price. But it was a once a week injection. And the FDA recently approved at the end of December a pill version of that medication that you take every day. And it's going to most likely, well, it's already much less expensive because it's less expensive to manufacture and they don't have to store it in any particular way, and it'll be more accessible to people than having that injection. So we're looking forward to 2026 in a world where we have at least a pill form of the medications, and we're hoping actually that some other pill forms of weight loss medications come out this year as well. And we are expecting at least one more, but we'll have to see what happens with that.
Yeah. And I have to admit, one of my questions to you the other day, and I'll ask for the listeners, if someone is listening and they have to run to the get ready for their hair appointment, or they're meeting at church, how would they make an appointment to see you to discuss which is the right medication for them, or if they're even a good candidate? How is
Yeah,
the best way to reach you?
yeah, the best way to reach us, we actually opened a second location. We're still down at Buffalo General Medical Center, but we've opened a second location in Williamsville, right off of Maple Road, Maple and North Forest. So the address is 705 Maple Road. And it's a lot easier to get to, in and out of, and parking is a lot easier for a lot of our patients. But you can certainly call us to make an appointment at 716-859-1168, and you could see me at either one of our locations.
Now, are you in the location where the rehab, where the Kaleida Health
Yes.
rehab is, and cardiac?
Exactly. So
Okay.
we're actually in a medical plaza it somewhat goes together as a metabolic medical plaza, I would say, because we have
Yes.
the kidney disease, oh gosh, I'm losing my mind here. The dialysis on the end. And then we
Yes.
have
Yes.
cardiology, GPPC cardiology, Great Lakes Cardiovascular. And then we have the diabetes endocrinology clinic next to us. And we are located in the physical therapy space. So if you're driving by and you see our sign, it is to the left of the sign that says physical therapy services, but we use that same door and entrance.
And I have to say, and that office space, I know I shouldn't say names, and I'm not going to say names. Used to be across the street from a great bakery that closed a couple of years ago.
Oh, no.
Oh yeah, it was a great.
It is across the street from a great Japanese restaurant.
Yeah,
So
yeah. Well, I guess because it's closed, it was a dessert deli. That's where you used to be. That's where you are across the street from. In case anybody ever went to dessert deli, not that desserts and well, I guess desserts and obesity do go hand in hand.
yeah, and they're
Um,
also okay. Fran, that's the one thing I want to tell patients is like, we don't, I will never judge anyone for eating a croissant, or a little piece of cake. We have to also enjoy life, and we're allowed to allow ourselves to have something that is not the healthiest. But as I teach, as we teach our children, they are sometimes foods and not all the time foods.
Mhm. True. Um, but back to medication. So when someone is taking the medication, let's say they've reached their ideal weight. Let's say they've lost 20 pounds or 75 pounds. Do they have to stay on that for the rest of their life, or can they maintain it just by maintaining what they eat?
So that's a great question. I often will talk to patients about about that in the form of also diabetes. If you take insulin for your diabetes, and it goes away, like your sugars improve, do you stop the insulin or do you just manage it? So a lot of diseases are like that. Any chronic disease is like that, where you want to get it down to a manageable state. But some, and actually, frankly, most will need to continue on some form of medication for the rest of their lives in order to control it. We do occasionally, like I said, I can compare it to patients with diabetes, and we do occasionally see that the occasional patient who can manage their diabetes with diet alone, but it is not the majority of people. And the same thing with weight is, yeah, certainly some people I'm sure can manage it with diet and exercise alone, but that won't be the majority of people.
Mhm. Okay. All right. Okay. I was just wondering about that. And if someone does stop the medication, how quickly do you think the weight would start creeping back?
So I found that so far, when patients do stop it, that food noise comes back relatively quickly. They will notice that food noise return within about a week or so, because that is the duration of the medication in their system. And so what we normally find is that the weight will start to come back on in obviously a very small amount over the first month or so. And we do see some weight regain. And I can't, it's not the same for everyone. In studies, it showed that there was, 15 to 20% weight regain. And I think that further studies could show even more if people were off the medication for longer periods of time. But it's really patient dependent. We have some patients who've had, bariatric surgery and they don't regain a single pound. And with patients who've had bariatric surgery and regain all the weight. And so the medications certainly coming off of it can cause you to regain all the weight.
Did you just use a term called food noise? Is that what you just said? Food noise?
Yeah, so I use the word food noise to describe that, the thought of wanting to eat, needing to eat. When was my last meal? What am I going to eat next? I'm not really hungry, but I know that that piece of cake is sitting in the fridge, and oh, I really like that tart, but I really don't need to eat anything right now. But because I like it, it's that inner dialogue in your brain that is telling you I'm hungry, but I'm not hungry, but I still want to eat this, and that's how I describe food noise. What I describe as food noise.
Yeah, and it is. I mean, I know personally that I've changed a lot of my eating ways since I took a program last year called Food is, what was it called? 40 Days to Wellness. And my food noise, and I always think about people do intermittent fasting. But one thing I know that I've started doing, I don't know if it helps or not. If I'm not doing a protein shake with fresh fruit, in the morning, I'll begin my day with like Brussels sprouts and salmon,
That's great. Yeah.
because I'm like, okay, I've never been a well, I have gluten and what is it? Whatever, and regardless what I have. I just find that eating, and sometimes if I have mashed potatoes, if I go someplace, I'll put a little mashed potatoes in there. But I just find that Brussels sprouts or broccoli or string beans and a protein in the morning also helps with food noise, because I guess the protein and some water or coffee, but something's working. I don't know what it is.
No, and I think that yeah, and as you tend to eat healthier and eat those less sugary foods, breakfast doesn't have to be the breakfast foods. And patients will often tell me, "Well, I don't eat breakfast. I don't like breakfast, right? I don't like eggs and toast." And who said you have to eat eggs and toast and cereal for
Right.
breakfast, right? You could eat
Yes.
salmon and Brussels sprouts for breakfast. That is totally fine.
Right. Yeah.
Yeah.
I mean, growing up, my father cooked the breakfast. And I remember we would have everything from these little pizzas that came in plastic, and you popped them in the oven. They were like the size of the palm of your hand. Sometimes we had hot dogs. Sometimes a hot dog, right? Sometimes
Yeah.
we'd have grits, but on the weekend we were so excited to have cereal or to have a waffle. But during the week, and I asked him one time, why did he have these meals? Because it was more of a meal. He said because he wanted to make sure we didn't get hungry between the time we left the house and had lunch.
Oh, yeah.
So
Mhm.
but anyway, can people exercise who are taking these medication? Are there any restrictions? I guess that's my question.
Yeah, so actually people should exercise while taking these medications. It is so the medications alone they're not magical, right? Certainly they are magical. They've helped a lot of people, but they cannot work alone. They work in conjunction with eating a healthy balance of food and exercise. And by exercise, I mean everyone's definition of exercise is different. my idea of exercise, I'm a very busy person, is whatever I can get in. You know, if it's carrying that stuff up and down the stairs a million times, if it's lugging the groceries in, if it's lifting that heavier case of water, or, you know, that is exercise to me. And I kind of, you know, I force myself, I'm like, oh, that has to go upstairs, I'm going to bring it upstairs. You know, I'm not going to
Right.
just sit it on the stairs. So I try to incorporate exercise whenever I can throughout my day, because formal exercise, going to a gym, is not really in the cards right now for me. And I always tell patients, like, there are certain times in your life when that may be in the cards for you. You may have the time to go to the gym, and sometimes you might not, and you just have to work with what you have, right? So I do tell patients, though, that some form of movement, at least 30 minutes a day, is very important for your overall health and to help with the weight management with the medications.
That is perfect. Be 30 minutes a day.
Yeah.
You can get that in between if you're
And
cooking
you can
or,
split it up. Yeah, you can even do 10 minutes 3 times a day, you know, with breakfast, lunch, and dinner, do a little 10-minute workout, you know, do something.
and I always say park it. If one of the best exercises, although when I'm with people they don't like it, is park at the furthest end of the grocery store parking lot and walk.
Oh yeah, that's a workout. You know,
That's
yeah,
how work.
that could be a workout. I mean, in the snow, I would caution with that, but you know, the Buffalo winter. But I would say, as soon as there's no ice on the ground, then yeah, the further you can park, the better.
Right, right. I've had people yell at me, say, "Why are you parking so far away?"
I know, I know.
And then I give in and park closer. Well, you know what? What else would you like to share with our listeners about? Well, what's a typical appointment like? What's a first appointment look like?
Yeah, so our first appointment is our longer appointment. We kind of delve into a few different things. So at our new center, we got the new in-body scale. So we have a new in-body machine. It is a body composition scale. So for those of you who don't know, the traditional scale, you stand on it, you get your 3-digit weight number. It just tells you your 3-digit weight number. We don't know what is muscle, what is fat, what is water. Our machine is pretty much gold standard for measuring the amount of water in your body, the amount of fat in your body, and the amount of muscle in your body. And that allows us to track what's going on in your body. So first we get that assessment. We figure out, okay, where are we at right now? Yes, you might want to be at a certain weight, but is that a healthy weight for you to maintain your muscle? And then we look, and then we talk about our options. So we also have a dietitian in-house, so you will meet with our dietitian, and we do have an exercise coach on staff, and we get you an appointment with our exercise coach, and she helps people of all exercise, I guess, of all exercise backgrounds, you know, so those of us who've worked out in our lives and those of us who have not. And so she can offer some advice and guidance on what you can even do around the house, and, you know, what kind of exercises you can do within your time constraints of your life. So we get you to see all these people. We talk about our options in terms of medications, and one of the biggest barriers right now is insurance coverage. So
Yes,
yeah, I
yes.
know. So, and it's changed because of January, you know, it's January. So a lot of insurance plans change in January. And so what I encourage patients to do is, number one, if you're going to book an appointment, do it soon, because I do book out quite a ways right now, but get an appointment. And then in the meantime, gather your information. So contact your insurance company and say, do you cover these medications? If you do, can I get a copy of the policy? So you have a right, you're paying into your health insurance plan. You have a right to get a copy of the policy related to these medications. And that's important because some people on the phone, you call the insurance company, you might get one person who tells you one thing, and the other person will say, oh, just ask your doctor. They just have to do an authorization, which certainly we do. We know we have to do an authorization for every single prescription we put in, but we want to know if you would actually get approved or not, you know, based on what their criteria is. And so they can give that to you, and you can share that. And we can just make sure that you meet that before we go through all the paperwork. So that's what I tell patients. We kind of, we explain, I kind of get to the root of where their concerns come from. And we can usually pinpoint something that's contributing to their weight in their lives.
I know you mentioned diabetes, and I know we have about another minute or two to talk, but you talked about diabetes. Are either asthma, or if someone is taking high blood pressure medication, does that have would that be something that would if someone has that, would be a pre-approval or, something like that for the
Oh, for
medication.
insurance, yeah, insurance purposes. So for insurance purposes, for some reason, they're taking diabetes as a disease that that yes, they'll approve the medication for, and they're
Hmm.
not necessarily taking obesity or like weight as the same level of disease. Okay, and we don't quite know why, and we're working on that with them, but. Certainly, when you have a diagnosis of obesity with other problems like high blood pressure, high cholesterol, lung disease. What are the other ones? Cardiac, heart
Asthma.
disease, asthma. It can contribute. You have some other factors. Insurance sometimes will look at certain. The ones that I mentioned are like the big ones, but there are some little ones that we can try to convince the insurance company that you would benefit from the medications for, like obviously losing weight would help with your asthma. To me that makes sense. To the insurance companies, they oftentimes just go by a checklist. And so that's where we get stuck, is as a physician, so many people qualify for these meds, and according to insurance not everyone does, right? And so we find a balance, and then we have some options for patients without insurance coverage. And luckily now that we have the pill, we have a more affordable option. It is still expensive, but it's a lot more affordable than the $1,000 injection. The pill form starting dose is now $150 a month, which is a lot cheaper than $1,200 a month for the injection, which is what it was before.
Yeah. Just one last question, because I know we have to go. How about pre-diabetes? Does that count?
Yes, prediabetes counts as a condition. It's basically a metabolic condition. It indicates you could have metabolic disease. Yeah.
Okay. All right. Well, Dr. Bonona, this is part one, because we haven't even talked about any of the weight loss surgeries. We haven't even touched on that, which I will get some dates from Joe, and I will put and I'll send you an email so we can continue part two on obesity, weight loss, and existing treatments that we have here
Wonderful.
at Kaleida Health. So thank you for being our guest on the Great Lakes Health Radio program.
Thank you so much for having me. I'd love to continue on this series.
Oh, thank you, Dr. Bernodes, who is the Director of Obesity Medicine at Kaleida Health Weight Management Center. I'm Francesca Messiah, Manager, Community Health Improvement, and next week you'll hear from my colleague, Cindy Bass from ECMC, and in 2 weeks, God be willing, you'll hear from me again. All right, thank you. Thank you for listening. Bye-bye.